Special thanks to Manjushri Madam and team AMOGS for giving me this opportunity. Is it? So the topic is male subfertility, and I'm going to ask you 3 questions, and you have to answer these questions at the end of the session. What is the incidence of male factors in infertility? Second is, what is the lower limit of normal sperm count? And third is, what is the difference between man and a woman? Now, Manjushri Madam says that you talk on what an egg wants. And I think the answer is, egg wants only one sperm. And we all know that जो जीता वही सिकंदर, लेकिन उसके लिए इतनी सारी मगजमारी करनी पड़ती है. Now, when a patient comes to the OPD, we immediately come to know what is the problem, depending on how the patient comes to you. If the couple comes to you, that means it is absolutely normal. But if a single person comes to you and he is a husband or a man, then probably he is having some problem and he knows that there is a problem, that's why he has come. And if single person is a woman, then maybe that man belongs to that elite group of 100 million plus sperm count and he says, मुझे कोई problem नहीं है, मुझे डॉक्टर के पास जाना नहीं है. So that is how you come to know where is the problem when the patient walks into the OPD. Now the problem is some of the males are so depressed and they are so frustrated that they just go into that vicious circle. Somebody has said that my luck is so bad that if I bought a cemetery, people would stop dying. And this is what happens with male partners. They get depressed and they are into that vicious circle and then they don't come out of this vicious circle. So whenever the patient walks into the OPD, from the looks you can actually guess that there is some problem. From facial hair, if he is too thin and tall, that means some chromosomal problem. Too obese and malnourished, there is a problem of nutrition. Masculine patients, even gym patients attending gym, you know that they are muscular, but they are taking anabolic steroids. And maybe that is the reason why they are having some problem with the sperms. Chronic alcoholic and smokers, where the day starts with beer and ends with whiskey, these are the patients where the semen count is definitely low. Now, our problem as a gynecologist is that we just ignore male partners and we do not take proper history, we do not do examination, and we should have a protocol for male partners. We should give privacy, we should give time to them, we should talk to them, and most important thing is you do a semen analysis from a proper person and you take help of a team of a sonologist, urologist, sexologist and a geneticist. Now, the incidence of male factor is rising day by day. Initially, when we were in college, our days, I remember we were taught that the incidence of male infertility is 30%. And now slowly it is going to almost 60%. And that is the problem. So the question is, where have all the cowboys gone? And this is really a serious issue. We must address this issue. And one of my friends from Dubai, she sent me this paper cutting from Dubai Times, which says that sperm drop could make humans extinct. And this is a possibility because the sperm count is falling drastically and you don't get 100 million plus counts nowadays, which we used to get 20 years back very often. So that is the problem. And this is because of many factors. Mostly it is because of the lifestyle factors, it is said, and of course environmental factors. Now, there is one more thing which we all should know, and that is the relationship between a male factor and a cancer. Because infertility and cancer is a cause of concern and they go together. We all know the relation of male infertility with testicular cancer, but not only testicular cancers, other cancers like acute lymphatic leukemia, melanoma, thyroid cancer, prostatic cancers and NHL, all are associated with male infertility, and you must have this correlation in mind whenever you are treating a patient of male infertility. And another thing is fertility preservation, and this is something which is going in a big way nowadays because we all should have that awareness in our mind that if the patient comes to you with say testicular cancer, a young boy, before treating that patient, please make sure that his sperms are with us, frozen with us, and send the patient to a fertility specialist and get those sperms frozen. Now, if you just look at the basic thing, we know that there is something that is a higher center which is hypothalamus, and there is something which is at the level of testes. If there is some problem at the level of testes, it is a primary testicular failure. It is called as hyperandrogenic hypogonadism. And if there is a problem at the level of higher center, then it is hypogonadotrophic hypogonadism. And this is a basic thing we should understand. And then we have to take a proper history of the patient. This is a WHO criteria which gives the extensive history. Though we don't take such an extensive history, we should take proper history, and in our format we have taken one point which I am going to highlight here is whether the semen collection is possible or not. And this is something which you should ask by a leading question, because many times the patients are absolutely normal, but when there is a performance pressure and when you start doing IUI and on the day of IUI the patient is not able to give the sample. So you should do this and then take proper history. Small things which matter, like history of lubricants. Somebody is using lubricants during sexual intercourse and they are not conceiving, you just stop lubricants and the patient conceives. So these are the things which are important, we all should keep in mind, and get an examination done from either a urologist or endocrinologist if you are not able to, if you will not be able to do the examination of a male partner. So get it done from a proper person, and we all should know that nothing succeeds like normal semen analysis. And if the man belongs to that elite 100 million plus club, then it is not going to have any problem except for ED. There are some situations where there is a performance pressure and a man is not able to perform at the time of intercourse. Now, it is said that it is very easy to do semen analysis badly. And if you get report from a DMLT person saying that semen count is itka and whatnot, then please do not believe in this semen analysis report. Get it done from a proper person, and this is something which we all should remember, and we all should know what are the latest criteria given by WHO, because this is something which is going to help us in our clinical practice. We should know the basic points, that at least take 2 to 3 samples. There should be a gap of at least 1 month in between 2 samples, and the parameters should not be more than 20% apart. Like something called, there is some situation like febrile illness, where you may get a severe oligospermia, but after doing semen analysis you find, after 2 months you find that the semen count is normal. Abstinence should be proper, minimum 48 hours, and you should ask them to have not the coitus interruptus, but the semen collection by masturbation, because it is going to give you the actual and accurate analysis. Now, there is a habit, some people have this habit of saying, "Tu kabhi maa nahi ban sakti, tu kabhi baap nahi ban sakta." Something which you should avoid saying in your OPD. This is actually the basic thing we all should remember, because it is said that even if the patient comes to you with azoospermia, you should discuss the limits of adequacy. You should say that below this limit the chances of conception are less but not zero, and do the centrifugation, and after doing centrifugation again see that whether the sperms are there, and you will get some sperms in the pellet, and this is going to help you while doing ICSI. So you should look for the sperm, a few things in semen analysis. You should look for the sperm morphology, sperm motility, and now this ABCD is gone. It is now progressive motility and non-progressive motility and immotile sperm, and this is something which is the new thing which you should know. And the most important thing is all motile sperms are alive. All motile sperms are alive, but all immotile sperms are not dead. And this is going to help you in ICSI, where you come to know about the vitality of the sperms, and if the sperms are non-motile but their vitality is there, then you can use these sperms for ICSI, and this is something which you should know. Then there are so many things which are there in semen analysis. Something new which you should know is CASA, which is not becoming very popular because there are some limitations, and something called as home semen test, where you can use your own mobile and do the semen test at home, and you know the count. Now, ultrasound is something which is important, because you come to know about the diagnosis of not only varicocele but testicular volume and obstruction and congenital bilateral obstruction of vast difference. And then you, apart from doing semen analysis, should do sperm DNA fragmentation index also. This is something which is not done as a routine test along with the semen test, but you should do it. Nowadays it is becoming a very important test, because it gives you idea about the fertility, especially in patients with low sperm counts. And you should do DNA fragmentation, which gives you idea whether the patient is going to conceive or not. If the DNA fragmentation is less than 15, it is considered as excellent. If it is 15 to 30%, it is considered as good to fair. And if it is more than 30%, it is considered as poor. And if the sperm DNA fragmentation is more than 50%, then you should refer this patient for ICSI. And if it is more than 25%, you should go for IUI. This is something which we all should know. Now, a most important point I would like to discuss here in last 4 minutes is azoospermia. And azoospermia can be either obstructive azoospermia or it is a non-obstructive azoospermia. And in non-obstructive azoospermia, there is a possibility that the problem can be at the level of testis, or it can be at the level of pre-testicular level, that is hypothalamo-gonadotrophic axis. Now, once you know the diagnosis, you should go ahead with the investigations. And the first investigation you should do in azoospermia is FSH. Because if the FSH levels are high, if you go to the basic slide which I have shown you, there is something called as hypergonadotrophic hypogonadism, where FSH levels are very high. If FSH is more than double of the normal, then that means there is a primary testicular failure and there is no point in doing any treatment, because there is a very low chance of conception with this situation. But if the FSH levels are normal, then there is a problem probably at the level of obstruction. And if FSH is low, then you should do testosterone, and then you should do LH and prolactin to find out whether there is a problem at the level of hypothalamus or the higher center. So that is how you should go. The first thing you do is do FSH. Then you have to do testicular biopsy. And if FSH is normal, then you get very good results because it is obstructive azoospermia. But even if the FSH levels are high, in non-obstructive azoospermia also you should do testicular biopsy, especially because there are some points of focal spermatogenesis, and you might get some sperms which are helpful in diagnosis in ICSI, and therefore you should do testicular biopsy in patients of azoospermia. And then, as I told you, there is some situation called as hypogonadotrophic hypogonadism, and this is a situation which is going to give very good results with treatment. And the treatment includes testosterone along with HCG and recombinant FSH. And this treatment of non-obstructive azoospermia, that is hypogonadotrophic hypogonadism, gives excellent results, and therefore you have to take help of an endocrinologist friend and start treatment for these patients, and they actually can father a child. So, of course in obstructive azoospermia, you have to either go for a surgery or you go for PESA-XC, and PESA-XC is going to give you excellent results, and therefore more and more people are going for ICSI nowadays with obstructive azoospermia. Now, genetics is something which is also important in male infertility, and you should know that there are many syndromes associated with male infertility, and we should actually know that syndromic approach has to be there whenever the patient comes to you with male infertility. That means you should do chromosomal analysis of the patient along with Y chromosome microdeletion. So this is something which is important. So last 3-4 slides, Nikhil. Some evidence-based interventions which are important is, in patients of hypogonadotrophic hypogonadism, treatment works very well. If there is an autoimmune factor, then steroids can be given. If there is infection, then only give antibiotics, and you can withdraw some drugs and then you can get results. Approach of uncertain efficacy is something like varicocele ligation, which is not going to give you 100% results, but more and more people are now going for varicocele ligation because you are getting good results with this. Lifestyle modification is always there in all situations. Antioxidants can help in oligospermia, and of course nutritional supplements. And something which is historical and disproven is androgens, which gives you temporary suppression followed by rebound production, antibiotics without infection, and use of loose undergarments to reduce the scrotal temperature, something which is historical and disproven. ART is the option for all these treatments. And the last thing which I am going to tell you is about something about Wiki donor, very good dialogues. The last part of the Wiki donor, the last sequence of events, Wiki donor Ayushman Khurrana asked Anu Kapoor, which of them are mine? And he is holding a party of all the IUID couples with babies, and Anu Kapoor says, all of them are yours. He says, all of them, 53. So he says, yes, you did all this, and this is your wonder. This is the wonder of your sperm. And the last dialogue is, entire world is a sperm. So this is a take-home message, that male factor is increasing day by day. We must know how to evaluate the male partner. Never ignore male partner. Do semen analysis from a proper person, and take help of urologist, sexologist, geneticist, and endocrinologist, and satisfy the male ego. And the last question now which I am going to ask you is, what is the difference between male and a female, or a man and a woman? And what is the answer? Ego. Ego is always there, but my answer is vast difference.
Vast.
Thank you very much. Thank you.
Thank you very much, sir.